Hello, everyone. Thank you for joining us. I'm happy to be here today with two titans of breast oncology, Dr. Joyce O'Shaughnessy and Dr. Mothaffar Rimawi. I'm Jason Mouabbi. I'm a breast medical oncologist at MD Anderson, and I'm going to let them introduce yourself. Dr. Joyce.
Hello, thank you. Good to be here. Joyce O'Shaughnessy, breast medical oncologist from Baylor in Dallas, Texas Oncology, and the Sarah Cannon Research Institute.
Hello, everyone. I'm Mothaffar Rimawi. I'm a breast medical oncologist from Baylor College of Medicine in Houston, Texas.
Thank you so much for joining us. You know, this is the exciting times that we're living in. You know, it's the era of antibody drug conjugates. They're everywhere. They cannot be denied. They're the future. And something very interesting this year happened. We learned about the results of the DESTINY-Breast09, a highly anticipated study. But to understand the DESTINY-Breast09, we have to go a decade ago and understand the Cleopatra study. So Dr. O'Shaughnessy, I'm going to start with you. Can you let us know a little bit about the Cleopatra study and why was it so important and the standard of care for this long?
Yeah, so that was a study of big phase 3, first-line metastatic, HER2 positive, both HR positive and HR negative, and it was paclitaxel or docetaxel taxane plus trastuzumab with or without pertuzumab. And it was just docetaxel. It wasn't just docetaxel, I think. Yeah, taxane. And so the median PFS went up from 12 to 18 months, and that was a big improvement. We'd never seen 18 months median PFS. But then the overall survival was also significantly improved up to 56 months, as I'm recalling on that. Is that right? And then the tail on the curve as you went out, to the 8 years and beyond, up to 12 years now, I think the follow-up is, there's a nice tail on the curve. So there was a greater percentage of patients who were basically living disease-free for a very, very long period of time. But to see that impact on survival, so that became our standard. And of course, we would, give the chemotherapy to maximum cytoreduction, as was done in the study. I think they kept the taxane going, actually. But if you stop the taxane, I think you were allowed to continue on your antibodies, I believe. But anyway, we would stop at maximum cytoreduction and continue the HP and then add the endocrine therapy if patients are HR positive. So that has long been our standard of care. It's got some limitations, of course, which we can talk about, but it was, the best data we've had in, like you said, long time.
Yeah, and patient benefited for a while, and some of them, that's the only treatment they ever needed in the metastatic setting. To your end, there was this tail at the end where patient essentially, should we dare say, a little bit cured in that setting. But yeah, so that was the landmark for such a long time. It was very hard to beat it because patients were doing well. But here comes the DESTINY-Breast09. Dr. Rimawi, can you let us know about the study design and what did they try to accomplish, that study?
So DESTINY-Breast09 was essentially the natural result of the successes that TDXD has had in prior lines, right? DESTINY-Breast01, DESTINY-Breast03, that moved it from third to second. And so the trial was designed to try and move TDXD to the front line. And the study randomized patients to the Cleopatra regimen, THP, which has been the standard of care, as Dr. O'Shaughnessy mentioned, since 2012. And then two TDXD arms, one with placebo and one with pertuzumab. And the idea of the pertuzumab arm was to make sure that if there is still a benefit for dual HER2 inhibition, even with a potent antibody drug conjugate like TDXD, that we don't miss it. So that's what it set out to do, is really to deliver on the promise of TDXD more in the front line and improve progression-free survival for those patients and overall survival, hopefully, by utilizing the most active agent that we had in the second line to the front line.
Oh, fantastic. Now, in terms of the results of that study, Dr. O'Shaughnessy, can you shed some light about how it improved the outcome of patient compared? Of course, now we only have the results of the combo TDXD pertuzumab compared to the Cleopatra regimen THP.
Right, so we're still waiting on the single arm TDXD data, so we don't have that. But as I recall, the median PFS was an astounding 40 months. And then the Cleopatra arm was 29 months, as I recall. Something was higher than we had with the Cleopatra historically, but 40 months. Wow, median PFS. And survival is starting to trend in the right direction, but not significant. It's very, very early on survival. and the TDXD kept going, until progression. And endocrine therapy could be added, but it wasn't added that much, maybe a third or something like that.
About
was
14%.
14 was a
Yes.
very small percent that actually
Yes.
got their
Yes.
endocrine therapy. But yeah, astounding results.
Yes, no, definitely. Now, back to you, Dr. Rimawi. The one thing that's different on the arm of the TDXD compared to the Cleopatra is that there is no this induction followed by a maintenance, right?
Yeah.
The patient were treated until something happened, either progressive disease or toxicities or non-tolerance. So what do you say to that? What do you say to that? Because, patient used to rejoice when you used to use the Cleopatra regimen, when you induce them with chemo and tell them, we're not going to do chemo forever, don't worry. We're going to stop it. Eventually, we're going to go to a maintenance regimen. What do you think about this idea of doing it under further notice versus stopping, doing an induction, and then doing a maintenance?
So the way the study was designed is to try to deliver maximum benefits, right? And we know, say from experience with TDXD in the DESTINY-Breast01, which is the third line and beyond, and from DESTINY-Breast03, which is the second line, that TDXD was being continued to be delivered and delivered successfully with, one might say, manageable toxicity. We're not going to say it's not toxic, but we have been giving it for a long time. So the idea was because nobody knew at what point in time does the TDXD benefit cease or change or plateaus, if you will, then the idea was to continue it. But the study did allow for the substitution of TDXD for trastuzumab in cases where there was toxicity per the judgment of the physician investigator. So it was not really mandated by the protocol. And now, it didn't happen a whole lot, but it was allowed. And actually, I want to go back to what Dr. O'Shaughnessy mentioned about Cleopatra. In Cleopatra, the chemotherapy was allowed to be stopped beyond 6 to 8 cycles. It was not required to be stopped. We just basically said, okay, we'll do it that way. And so, and the idea was that, honestly, that many of us don't think that we can continue taxanes too far beyond 8 cycles without really starting to see the effects, particularly of neuropathy, I think most of us are concerned about. So the idea here is that, the trial was designed with the idea of delivering the treatment for the maximum possible benefit while allowing a switch for toxicity. Now, there are a couple of things that the study results showed. One was that the duration of response was very long. So that TDXD is inducing a very deep response. It increased the response rate, doubled the complete response rates to about 15%. All of this is telling you this is not happening in only 6 to 8 cycles. It is happening longitudinally. But it also showed us with the duration of treatment that treatment was being held or delayed, in a significant portion of patients. So the moral I think I have of this is that doctors and patients were deciding on that together. Hindsight is 2020. Should we maybe have thought in the design of the study of maybe, a place where you stop and then you switch to something maintenance or not? Yeah, you could argue that. But the way the study was done was really not thinking that it would be a slam dunk that way, because I don't know that any of us thinks that 6 to 8 cycles of TDXD are going to make the difference that DB09 made, to be clear, over Cleopatra. And I have a hard time thinking that those 6 to 8 cycles alone would have been enough for us to realize, as Joyce mentioned, from 27 months to 40.9 months, 3.5 years.
Yeah, impressive.
Yeah.
So yeah, you're right. About 10% of patients, 1 in 10 patients on that study eventually substituted the TDXD to trastuzumab.
Yeah.
But back to you, Joyce, to that question. I mean, a lot of data recently came in that field, especially in the maintenance. So first, the patina, right? The patina came showing us that in patients who are hormone positive or triple positive in this case, that switching to a maintenance, if you achieve a good response, switching to a maintenance with HP, adding a CDK4/6 inhibitor on top of an endocrine therapy can also achieve this 40 months plus a median progression-free survival. And at this San Antonio, we're going to get another maintenance strategy with the HER2 clamp 05 that is looking at the addition of tucatinib on top of this HP. And we know that the study is positive. Having those studies, how are they going to fit now that people are going to start adopting more the DB09 strategy?
Now, I think it's a very important question. And I think it's going to be individualized for patients. There are certain patients, like those at high risk for brain metastasis, that, and those are generally, I mean, all HER2 positive patients are at high risk for brain metastasis, right? But particularly those with large primary cancers, heavier tumor burden in general, but also ER negative disease. And, you know, brain metastases are not addressed by the Cleopatra regimen. They're not addressed with the induction, and then they're not addressed by patina. Not that we've seen data. Now, they probably will be addressed, at least to some extent, with the tucatinib. We'll wait and see. We know it's a positive trial, so we'll have to see the brain data. But the brain effectiveness of TDXD is unparalleled, absolutely unparalleled, right? So that's super important to me. PIK3CA. Very important. Very important. You know, before we make any decisions, if we're going to not just give everybody, we have to know the PIK3CA, because even in DB09, the PIK3CA only had 18 months. You know what I mean? Like way worse than those patients who are PIK3CA wild type. You know, so that's a very, very important subset. And then those with, I think, really just heavy tumor burdens. It's just as somebody, again, where you just have to get the deepest response, as you said, you know. And then the CR rate that doubled from like 8.5 to whatever it was 15% or something. That's a big difference to get those CRs. But on the other hand, there are some patients that present with oligometastatic disease. You know, they present with a triple positive breast cancer, for example. It's a big cancer. They got nodes, and then you get a PET, and you got oligometastatic disease. You know, some people feel that may not be a bad patient to do a Cleopatra-like approach, do an HP and palbociclib approach. One could also do induction with TDXD. You know, do 2DXD and then switch her over to a maintenance therapy. I think we're going to individualize. I will tell you, I'm dealing with this right now with a patient in practice. You know, and it's not so easy to give up on a treatment that somebody's doing really well on. She's a bone-only patient, and she's got a history of cardiac. And I wasn't sure I was going to be able to get much in the way of a HER2-based therapy. And we happen to have a very talented cardio-oncologist who said, treat, you know what I mean? And so she's done great. Her heart's done super well with it. And her PET's long been negative now. And she's doing great. And she was asking me, you know, when can I go over to some HP, et cetera. But, you know, the more we talked about it, and I'm like, are you having any toxicity? And she's really doing very well. I think we may have reduced the dose at this point once or something for some fatigue. But, you know, at the end of the day, neither of us has really decided, hey, this would be the right thing to do to switch you. Yeah. So we're maintaining, because, you know, if it's one of those, if it ain't broke, don't fix it type of thing, it's hard to change off of something that's working well, as long as people are doing well on. She's having an excellent quality of life. So I think it's going to be individualized, but there are patients, there's such a heterogeneous disease, and those are some of the variables I think that are going to be just discussions with patients.
Sure. No, definitely. But there is something you mentioned that I really like, and I want to get Dr. Rimawi's input, because he studied that extensively. 30% of the patient on the DB09 had a PIK3CA mutation.
Yes.
I know that PIK3CA and HER2 positive is a great interest of you, and you have a DoD grant to study those. Can you shed the light about why it's important, and what did the DB09 give us in terms of advantage?
You know, when Dr. O'Shaughnessy was sharing her thoughts, I was thinking, she either read my mind, which she is talented enough to do, or that we just basically share very similar views on this, including the if it ain't broke, don't fix it. We just were aligned completely on that. So such a privilege to be discussing this with her. I completely agree. I think PIK3CA is a big variable here. And earlier this morning in a conversation with colleagues, I was just mentioning about PIK3CA. So what is the PIK3CA is, of course, the PI3 kinase pathway. PI3 kinase, AKT, mTOR pathway, is a downstream signaling pathway for HER2, or the entire epidermal growth factor receptor family. Okay, And so as they homo and heterodimerize, they signal through either the MAPK pathway or the PI3 kinase pathway. And these are major signaling nodes, potent pathways that activate transcriptional programs that actually result in resistance. Now, when you inhibit the receptor layer with potent therapy, theoretically you shut off the signal from the membrane, and then you shut off the PI3 kinase pathway. However, an activating mutation anywhere along that axis in the PIK3CA, in the AKT, or activation of mTOR would result in activation of that pathway, and you bypass. It's like a short circuit. You bypass the receptor layer, and now you inhibit all you want on the surface. It's not going to work. Actually, in the grant that you mentioned, we showed that actually if you treat tumors with pure anti-HER2 therapy, without chemotherapy, that have a PIK3CA mutation, there are, in our neoadjuvant trial, not a single one of those patients achieved a pathologic complete response with a combination of lapatinib and trastuzumab, which is just pure anti-HER2 therapy, which tells you that that type of mutation essentially shuts off or bypasses the inhibition, the potent inhibition of HER2. Therefore, as Dr. O'Shaughnessy mentioned, there is really the issue of, if that is there, how are those patients going to do on maintenance, right? Because you're not having, you might have given them some chemo, which should not care or should equalize, but we still know that they respond less to chemo, less to T-DXd, less to CDK4/6 inhibitors, right? So are we going to see similar outcomes in those patients or not? So I think that is something, it's just one. Another element along the lines of scientific interest, we are also looking at the emergence of ESR1 mutations in ER-positive, HER2-positive disease. And just the early signs that they are not any less frequent than in ER-positive, HER2-negative disease, as long as you essentially target ER with an aromatase inhibitor or endocrine therapy. And so one would argue that, again, you're really, what is going to happen to these patients? Are they going to have ESR1 mutations emerging? So we really have to be paying attention to biology right now. My view is that unless the patient, and I think this is what also Joyce mentioned, unless the patient has a contraindication to TDXD and pertuzumab, I think most people are going to start with that. I think the question is, until when do you continue it? And that would be my strategy, is if this combination is approved, my strategy would be start with the dual, with the TDXD pertuzumab, unless you have a reason not to, bad lung disease, concern about toxicity of some sort, and then continue that. Now, continue that until bothersome toxicity beyond maximum response, until maximum response plus 2 cycles, in perpetuity as long as the patient is doing well, versus a switch to an all biologic regimen. I think that is where we have to allow doctors to be doctors and for the patient-physician relationship to rule supreme. One last point related to this, I share the views of Dr. O'Shaughnessy on patient perspective.
Certainly.
I shared stories about patients who I convinced, I actually started patient on pure anti-HER2 therapy without even induction. And did well for 2.5 years and progressed. And we talked about it. And I said, let's do TDXD. She had to be convinced to take TDXD. And every cycle she would say, I don't want it. I'm reading. I'm worried. I'm all that. Before we got to San Antonio, I started to say, you've been doing so well on it for so long. How about we give you Christmas off? Let's just give you a cycle off and just have you celebrate. You know what she said? No.
She's doing what?
No. I am going to continue. She said, you may have to stop it later, but right now,
yeah, that's fantastic. That's amazing. And that speaks to how patients are doing. Yeah, that's true. Dr. O'Shaughnessy, there's something very interesting when you look at the PFS curves. The separation seems to happen at 5 to 6 months compared to THP, right when it's time to drop the chemotherapy on the Cleopatra arm. Does that speak to the fact that we need to continue TDXD and not stop and go to a maintenance to get that fantastic benefit that we see the 14 months plus, or you don't think that has a role?
I think that they're very different regimens. TDXD is so powerfully pro-apoptotic, and that dual inhibition that you get with TDXD and pertuzumab, you're getting rid of that HER family, and you're just, it's extremely good anti-tumor activity. So it may be that curve speaks more to the fact that on the Cleopatra regimen, that stopping the taxane isn't the best thing to do. Probably because you got 30% PIK3CA and other mutations in that pathway too. It's not just PIK3CA. I don't know that we really know for sure how long to keep going with it. At some point, it's just going to have maximum cytoreduction. You're going to have the maximum cell kill. And then it's really a question of maintenance, essentially. And it may be different for different patients depending on how much tumor there is, too. And a lot of these patients are de novo metastatic, so we can go by their breast exam and we're going by their PETs. And so we kind of know when we've got maximum cytoreduction. And then the question is, what's the best way to bar the doors in terms of resistance emergence? And this really, when you want to get your metastatic disease down to the smallest possible amount in order to prevent or forestall emergence, essentially, And so that would speak to just maximizing it. I think it's going to be different for every patient. It's going to depend on how much cancer there is, whether things like ctDNA will help us understand. You like those. But will help us, depending on the trajectory, what's the slope of that, clearance curve, et cetera. If it's trickling down, that's a different math. That may help us eventually. But the issue is going to be, is the patient ultimately going to be better off by modifying dose? Yeah. Maybe even modifying schedule till 4 weeks, for the patients that are well out beyond that year, you know what I mean? I do that now with HP, when I'm giving subcutaneous HP. The ASCO, we just go every 4 weeks sometimes for patients that are way out there, you know what I mean? And you're obviously decreasing your dose a little bit, works fine, but anyway, dose modification, ILD risk is less when you have less peak dose. It's less. It's a dose-related phenomenon. So if you reduce dose, you're reducing risk as well. And the ILD stuff really seems to be most in the first year. It kind of plateaus. There's a little bit. We have to still be vigilant, but most of it, so we can then spread out those CT, non-contrast CT scans. So I think that it's the issue of maintenance. What's the best way to keep this cancer suppressed?
Yep. So that's a perfect segue for my next question. So my next section is going to be talking about tolerability and adverse event of that drug. But first, before we go into the elephant in the room about that drug, which is ILD, if something very interesting when you look at patients who stopped taking that drug, it's like the minority was because of progressive disease. A lot of patients stopped that drug for other reasons than progressive disease. What do you have to say to that, Dr. Rimawi?
Two things. One is, everybody should be mindful that such a potent drug also has potential side effects. And that we medicate for them, right? We give the patients 2 or 3 anti-nausea medicines, right? We basically, do CT chest more often to screen for ILD. We dose reduce for fatigue. And try and give them other things, optimize the other medical problems and the anemia, and ask them to exercise. So we proactively manage the toxicity in it. But there is going to come a time when the patients develop toxicity. But I would contend that also when you give a medicine for so long, you have a higher chance.
40 plus months.
You have a higher,
right?
Yeah, you have a higher chance of people developing, if you do anything long enough, you increase the chances. You know how they say, the only way for someone not to make a mistake is not to do anything, or not to get into a car accident is not to drive. So, the idea is like when you treat for so long, there is a higher chance that you would develop toxicity, right? So it's both. It's a drug that has toxicity. The pneumonitis and the ILD is stubborn at that 10%, right? So we know it's real, and we know it happens, and there are risk factors that we're trying to identify. but we've become a lot better at detecting it. We've become a lot better at, managing it if it's grade 1 and putting the patients back safely on TDXD or stopping it altogether and stopping or preventing a progression into grade 3 and beyond pneumonitis. So, and, tomorrow I'm going to be presenting the PRO data for DB09 and THP. And, I would just say that the tolerability data for TDXD is quite reassuring. If you look at many of the potential side effects by quality of life questionnaires and PRs. Now, again, we're not saying the drug is without toxicity, but we're also dealing with a very serious disease, which is metastatic breast cancer. So we have to be mindful, and I think Joyce is spot on when she said that you have to balance the benefit that you're trying to give the patient with the potential side effects. And it's a different conversation with every patient. But I do think that tolerability is a factor. And I think the idea becomes different people will tolerate the different medicine at different doses for different durations. And also they have different disease dynamics and responses, right? One would say that if someone is responding but still has a lot of disease and is telling you, doctor, I'm tired, you say, no, let me help you get a few more doses in you so we can kind of maximize the benefit, right? Versus someone who has been on it for a long time, like the patients we're talking about. If they come to you and they say, I really feel like I need a break, you're like, let's give you a break. So I think all of these conversations are nuanced, and I think I feel that it would be presumptuous for me to kind of go and assume that I know every scenario that's going to happen in every clinic between every physician and every patient. But the data is out there, and hopefully it becomes available to patients as a therapeutic option, and then basically let that relationship between the physician and the patient kind of take into consideration the comorbidities, the preferences, the volume of disease, other biologic and pathologic factors we talked about. This is what makes the art of medicine.
Fantastic. Joyce, let's tackle ILD a little bit, and I want to hear some pearls from you, from your practice, how you do it. So ILD, you're right, it hovers 10, 12%, depending on which study is looking at TDXD. It's always there. We've seen it again in DB09. 5 deaths, so 5 grade 5s attributed to the ILD from TDXD. In your practice, how do you monitor for it?
I use non-contrast chest CTs, I do every 9 weeks. And really looking for that grade 1, that asymptomatic. I tell the patients up front that we need to do this because I've got to find this asymptomatic. And, if they do have any symptoms at all, of course, we need to know. But, I need to know if it's in the context of, a URI, for example, or allergies are kicking up or whatever. Because I tell them, let them know that if it's asymptomatic grade 2, we're going to have to stop. And so that they really, we really are on the same page about getting these scans done. If there's anything there, I stop and I give a course of steroids, about a 4 or 5 week course of steroids, and then repeat the scans. It takes quite a while for it to go away completely. So, but I would resume. I resume at a lower dose. I go down a dose. I don't want it to happen again. Basically, and I know that the data show even with maintaining that dose, it's still only about a third of patients that have a recurrence of it. But still, I'm going down because I think this drug has some therapeutic window on it there. But then, it's very tricky if they're a little bit symptomatic. Because there's all kinds of reasons. We have lots of allergies in Texas, for example, a lot. And then it's flu season, et cetera. So it's hard. And but we have a little bit of data on re-challenge with grade 2. But most of the time, if I think it's ILD, I will not re-challenge if it's grade 2, if it's real. But if I think it may not be, reflux is another big thing we see. So I have patients. If they have a history of taking them, I make sure they're taking them because that's going to confound things as well. But I really think that the only time I've seen trouble with the agent was very, very early on when it first came into our practice. And we just have to be really have a heightened awareness. I think the hardest thing is for patients with a lot of other lung disease, and they will have a pleural effusion, it obscures some of their lungs. Those are the most difficult patients. But when in doubt, err on the side of holding and then treating with the steroids. I think that's really the key.
Fantastic. One last thing I want to touch base on with Dr. Rimawi, the nausea. All right, so I feel in my practice since I start implementing olanzapine, low dose olanzapine, 2.5 milligrams, sometimes even half a tablet. I tell them take 1.25. It changed completely their perception of the drug. What has been your experience?
I agree with that. So we medicate for it as a highly metagenic, but I cannot take credit for it, but a clinical pharmacist recommended that to me. And so I was like, well, let's try. And it works. I agree with you.
Yeah.
It works well. And I think to the extent that if the patient do well for a number of doses, we start dropping some of the other meds, particularly if you're starting to be worried about their blood sugars, you can drop those steroids. And if you worry about, some of the side effects like constipation with anti-nausea medicines, you can kind of lower it a little bit. But I do agree that olanzapine has really transformed the way we see nausea. And I actually use that trick that I learned from our clinical pharmacists in other regimens as well.
Yeah, fantastic. Any last remarks do you guys have?
Just I agree with what Mo said too about how fatigue can be cumulative.
Yeah.
And dose reduction really does help. And then I've had patients go on with their dose reduction and do well for a very long period of time. Then they're tired again, so you dose reduce again. You know what I mean? So dose reduction really does work for that. Olanzapine is unbelievable. And those are really the main things.
Yeah. That's your mouth.
Oh, one more thing. So for your patients that are super, super concerned about alopecia.
Yeah.
I mean, like, won't take the drug because of alopecia.
Yeah.
We have a little conversation going in our clinic. We haven't seen it at 4.4 dose, so a slightly lower dose. Not that we want to do that, on a routine basis, but at any rate, that is a way to potentially reduce the risk of alopecia, because for some patients that's an absolute huge thing for them.
That's a fantastic insight.
Yeah. Or just those who get a great induction, or on it for a year, they're doing great. And a lot of times the hair will grow back anyway. But if it doesn't, just a slight dose reduction could make that happen for them.
Oh, fantastic. Thank you. Any final remarks, Dr. Rimawi?
I'm taking notes from all of that. And I think, I think that this is a very exciting time for HER2 positive metastatic breast cancer. I think since the late 90s, early 2000s with Dennis Slayman, Dr. Slayman and his trastuzumab Taxol trial, then in this meeting in 2012 when the late Dr. Jose Baselga presented the Cleopatra trial, and then to see now, a quarter decade later from those, from the onset of anti-HER2 treatment, to see that what we're debating today is which very highly active regimen do we give our patients, and that we're talking about progression-free survivals that exceed 3 years on the median, to your point, and many patients doing a lot more. So this is very exciting times, and I would just say that we need to stop and celebrate for these successes for the sake of our patients, and then also have the conversations with the patients, take into consideration all the factors we mentioned: efficacy, tolerability, biologic factors, patient preferences, and then make those determinations. It is a little bit of a challenge, but a good challenge to have in the service of our patients.
For me, as a last remark, I just want to say, reading about HER2 positive disease before the era of HER2 directed therapy used to be the worst cancer.
Yep.
I want something for our triple negative patients.
Right.
Yeah.
We need to help. Thankfully, we're helping a lot our HER2 positive cancer. It becomes the most treatable right now that we have when it's in the metastatic setting. We need to help other subtypes. And with that, thank you so much for joining us. It's been great. Thank you.